my screen visible and am I audible?
Yes, yes.
Yes, sir.
Right. Yeah. Good evening, ladies and gentlemen. Thank you so much, ARC, AIOS, and greetings and regards from the land of Lord Jagannath. As I present before all of you a compendium of situations occurring in a 73 years old male, having been on tamsulosin for 21 years, presenting to us with a dense cataract, a rigid pupil, and required a T9 toric implant. The first challenge to deal with was obviously the rigid and small pupil. So after fashioning all the three poles and putting in visco, in goes the belugan ring into the eye. The technique that has worked the best in my hands is to make sure that at least the distal and one of the side scrolls are engaged right at the time of insertion of the ring. This gives us the liberty to engage the other two scrolls later on in an atraumatic fashion, less of maneuver, the side scroll, and then the proximal one in the end. And after all the four scrolls are engaged, the pupil can be brought down to a more central location, which eases our subsequent maneuvers. An image-guided CCC is the next step to ensure the toric implant is properly covered all around. The next challenge is to negate the possibility of an IFIS and at the same time negotiate with the dense nuclear sclerosis, for which we choose a minimalistic fluidics. The IOP sits at 20. And we also add on a little bit of longitudinal power with the torsional power that is existing in the machine as we go ahead and chop the nucleus. This is not out of the routine at all. We chop each pie and separate it from its lateral adhesion. This is the last chop, and the CD is doing pretty well at the moment, sitting at 1.83. We go to the quad mode. The IOP sits at 20. And as we reach the fag end of the quad mode, we see that there's no evidence of IFIS thus far. And the CDE is doing pretty well, sitting at around 11 point odd for such a dense nuclear sclerosis. The next part, and perhaps the most important part of the challenge, was to ensure that the T9 toric implant sits along the line of implantation as planned. And I would not want even a drop of visco to seep into the capsular bag, because slight degree of postoperative rotation, even a 10% loss of toricity of a T9 can extrapolate into massive amounts of residual astigmatism in the postoperative period. So to ensure that the visco doesn't go into the capsular bag, I revert to my trusted technique of everybody's trusted technique of implanting the toric into the capsular bag under cover of BSS. I just wanted the capsular bag to get filled up with the lens. So allow the lens to sink in, and then align it along the implantation axis in an image-guided manner. But we still have the bulky Mulligan ring to come out, so we need a visco support. So over the liquid film, we inject some amount of superficial viscoelastic, which is enough for us to disengage the scrolls one by one. And as we do that, the pupil comes down, and the iris forms a barricade now. It shells off the capsular bag. So safely, by using the iris barrier, we put some amount of, more amount of viscoelastic just to form the anterior chamber a little more, get a little more space so that the hook of the plunger can go in. There we inject some visco. Now the hook can go in, engage the scroll, pull it back. Bimanual irrigation aspiration then ensures that all the superficial viscoelastic is removed along with the iris pigments, whatever are released. Now, despite of all these measures, when we finally cross-check the alignment of the toric IOL by pushing the iris aside, we will see that it is a little off axis, not much, but a little off axis. So we just give a little nudge with the irrigation cannula to bring it back to the midline. We close the case here when the alignment is ensured. A snapshot from the proctor screen on the postoperative refraction table of the patient would show that this eye, the right eye, does not need any correction at all, while the left eye still needs a T6 implant. Thank you so much for your benignant participation. Thank you, ARC.
Thank you, Dr. Anurag. That was a very nice discussion, especially the fluidics, which is a very major role to play in this proper iris situation. But I want to ask you, why did you choose a 6 mm rexis, as I saw on your Varion overlay? Don't you think it's a little larger rexis?
Ma'am, there are 3 ways to do it if you're doing it image guided. Actually, you can do a 5. You can choose a 5 mm and stay on it. You can choose a 5.5 and choose a little beneath it. I choose a 6 and stay well beneath it. So, I mean, the size of the rexis I land up in is 5 to 5.5, but I choose a 6 because I want the dashed line of the image guided system to be outside the perimeter of my CCC.
then it makes sense, because toric IOL especially needs a good rexis overlap. And just for the audience sake, I'm asking this question. In which kind of a floppy iris situation would you not use pupil expansion devices and just use viscomediasis? Is it something you would take a call along the way, or any case on tamsulosin and such you would always use a pupil?
Oh, no, ma'am, not at all. I mean, I would manage the case without a pupil expander whenever and wherever I can, because I always use low fluidics. I always use an IOP of 20, so IFIS does not trouble me on a great deal of occasions. So this patient was a little different because he needed a T9, and I wanted to make absolutely sure that it sits right at the implantation plane. So if it's not a toric implant, then even if it's a multifocal or a trifocal implant for any other ATIOL, whenever and wherever I can, I would manage it without any expansion ring whatsoever.
Very good.
Can I say something?
Expert panel, anything to add?
Can I make a comment?
Yes.
Yes, sir.
There are 2 points which are really cut off for me as far as the tamsulosin and the iris hooks are concerned. Preoperatively, I decide what the pupil size. The pupil size is less than 6 millimeter. Straight away, I go in for a Mulligan ring or an iris hook or a BX ring in the beginning itself. And also the density of the cataract. The cataract is quite dense also. Grade 3 and above, then I would straight away go. So he did all the things right in this particular case. Only thing is, I would use Halon for, especially when you're using a toric lens, I use Halon because it expands the bag, easy to remove also. And you can actually rotate it instead of putting it in the balance salt solution. Of course, he did it well, but when you use Halon, the cohesive viscoelastic is easy to remove, can go underneath the lens also and remove it. It's not a problem at all.
Yeah, I thought it would be a little difficult, sir, once the pupil assumes its normal pre-op size to go underneath the IOL and still ensure that it is not rotating and it's still maintaining its alignment axis. So that's the reason why in fact, for my torics, I normally do not put any viscoelastic at all. But in this case in particular, I was a little wary of the fact that I would not be able to approach the posterior side of the IOL. It'd be a little difficult for me to go with the aspiration cannula behind the IOL to plane at all.
Dr. Mahipal, Dr. Ram, Kumar, any thoughts over the last?
I would just like to congratulate Anurag, great planning and execution of a difficult case. IFIS case, small pupil, hard cataract, keeping the IOP at 20. And there's no point allowing the pupil to come down, and with a lot of foresight, putting in the expanding device right in the beginning. I think that's very important. You don't stage the pupil or nick the pupil and then start trying to manage it. And then subsequently, the right kind of rexis size, and keeping the IOP at 20 is also an extremely very moderate parameters, which kept the surgery very controlled. And the fact that you never even took out the phaco probe once out, I don't know whether it was edited out, but when it is during the introduction of these instruments, then often that the iris tends to follow. If we're able to complete the entire phaco procedure, if necessary, injecting the viscoelastic through the side port when it's necessary, lessens the chances of any pupillary prolapse. And then, of course, I would tend to agree with Mohan, maybe because I don't implant lenses under saline. I use a viscoelastic, and maybe if you have used a high molecular viscoelastic, removal will also be quite easy. And as you very rightly pointed out, in spite of leaving the lens on the table, it's extremely important at the end of the surgery to check that it's very well aligned, because just the removal of the device or even the removal of the speculum can sometimes misalign your lens, and checking and ensuring that it's right on axis, especially when it's a T9, is extremely important. I think I wouldn't have done anything differently. Great take-home points. Excellent.
Right.
So,
Thank you.
Anurag, you should be sitting on the panel and not be the presenter, because I think you presented very well. And everything was so preempted correctly that, everything.
Sitting on the panel is much easier.
No, it is not much easier.
I have to age a little more, ma'am.
Yeah.
No, I think being
No,
out.
but you preempted everything, and it was planned.
Anurag, what are you
so
saying?
well
These
that,
guys on the panel are.
You are
These guys
mistaking
are
our
old.
age.
Yeah.
Anurag, you are mistaking our age.
Yeah.
Maybe Ramurthy is little old.
I was it's just an attempt to flatter myself, sir.
Anurag, we are not that old.
Yeah.
You're not, ma'am. You're not.
You said everything right except the age part.
Except the last part.
We take strong offense to that.
I just fear the trophy just will be drawn from me.
Yeah.
Any questions from the attendees, or do we?
I just wish to add in IFAS, as Mohan said, the first thing is that you should be prepared beforehand, and an OPD assessment of a case of a patient on tamsulosin is very, very important. Right in the OPD, you should be able to see whether the patient is dilating or not, and maybe start them on preoperative atropine. The other thing is that you should have, now you have this phenocaine that's available in India commercially. So I often use that intracamerally. And as Ram said, it is very, very important to do it right in the beginning, to put the expander rather than try and do things that it will, when it happens, we'll do it. The other thing is, which Dr. Rohit Om Prakash has very nicely shown, is that we don't give enough importance to the side port.
Side port, yeah.
IFAS, it is very, very important to have a side port from which is not, it is often from the side port, if it is not constructed well, that the IFAS starts the problem of the iris prolapse and the pupil keeps going down. So a couple of things, otherwise an excellent presentation. I have not really, as Ram has said, I don't use a BSS for doing a IOL implantation. I don't think it's going to.
And the sign of age.
Sorry? Same age.
And the sign of age.
The younger surgeons use BSS.
Now it's time for me to hide my face.
No, sir. Even I'm a young surgeon and I use viscoelastic.
We saw the wink, sir. We all saw the wink.
So that's
Thank you very much. I think I'll